I just want to introduce Hyung Kim, who is, I think, one of our thought leaders within urologic oncology. Hyung and I first met, as you heard us chit-chatting, in 1996 while he was training under Dr. Charles Brendler at University of Chicago in his residency. And then, as you heard, he transitioned to UCLA. And at UCLA, he did 2 fellowships. I believe Hyung's first job was at Roswell Park. And then from Roswell Park, he was recruited to go and lead the urology division at Cedars under Bruce Gewirtz, who is the chair of surgery. And then more recently, Hyung has really elevated that program to the extent that it's now a department. So Hyung is a newly minted chair of a department, or about to be a newly minted chair of the Department of Urology at Cedars. And Hyung is on the GU steering committee for the NCI, and so we interface frequently about trials that are emerging, and it's been a pleasure to reconnect with them in that way, among many others. And one of the things that Hyung and I were talking about was just really highlighting some new clinical trials that were opening up within the kidney cancer space. And so, and in fact, Hyung is the PI of a really innovative and I think thoughtful trial, I think out of SWOG. Is that right, Hyung?
Yes.
And so so anyway, we had been chit-chatting. We thought it would be a great opportunity for us to hear about advanced kidney cancer, and then for us to hear about opportunities, particularly opportunities to help participate in Hyung's SWOG kidney trial. So Hyung, it's great to see you. We'll see you in Chicago soon for the AUA, but thank you for taking the time tonight. We really appreciate it.
So Ted, thank you for the invitation. It's great to be here. It's an honor to be here. I wish I was there in person despite the cold. Good to see you, Ashley and Kent, and I see Maha. And you guys certainly know how to conduct trials, design trials, and so my ulterior motive today is to tell you about PROBE and get your help enrolling patients to that trial. But let me start here with just a quick disclosure slide. This is a drug that came out of my lab. We're gearing up to do a first-in-human study. Hasn't happened yet. Interestingly enough, I designed the drug initially for kidney cancer and prostate cancer, but when the companies get a hold of it, they often have other thoughts, and the first-in-human trial is actually going to be in colorectal cancer. We're going to talk about some serious things, but before we do, I want to tease you with some trivia. If you come to Southern California, what I would encourage you to do is go on a hike. We have some fairly high mountains. There are 3 peaks that are over 10,000 feet, and I've listed them here. San Gorgonio is the highest peak, but one that I think is pretty fun to hike is San Jacinto in the middle. And this is what it looks like. It's actually in Palm Springs, and it starts in the desert at sea level, and you climb to the top. When you start to hike, and you got to do it in the spring or in the fall, otherwise the temperature is too harsh. But when you start, it's about at the bottom, it's about 120 degrees, and at the top there's snow. So you get to see 2 very drastically different climates on this single hike that you can do in a day. If you go to backpackers.com, they rank this as the 5th hardest day hike in the country. And a lot of people, hikers, do get rescued on this hike, unfortunately. And every couple of years, someone does die. Halfway through my talk, I'm going to give you the tips that you need to do well on this hike and to survive it. But it is the highest climb in the 48 states. Mount Whitney has a higher ultimate elevation, but it starts at over 8,000 feet, whereas this starts at sea level. the total elevation change is about the same as if you do the Mount Everest hike from base camp to the top. All right, so here's a quick outline of what I want to talk about. I want to talk about the role of cytoreductive nephrectomy for metastatic kidney cancer, and then we'll have a discussion if you guys would like. And then as time allows, I'd like to give you a quick update on where things are for adjuvant therapy for high-risk localized renal cell carcinoma after nephrectomy. So here's a picture of a typical patient we might see. You can see a large renal mass with thrombus in the IVC, and you can see a metastasis in the liver, and I've highlighted that with an arrow. So it's a newly diagnosed metastatic kidney cancer. Should you be doing surgery? When should you be doing surgery? So let's address this first question about surgery. This patient that I showed may not be the best example, because with an IVC thrombus, that may be an argument that pushes you towards surgery because that can lead to morbidity. But if you didn't have that, you would certainly be debating the role of cytoreductive nephrectomy in your tumor board. These are two historically important studies, both published in 2001. Interestingly enough, when SWOG was conducting their original study of cytoreduction, they had slow accrual, and so they invited EORTC to join them. The idea was to have two parallel studies with same eligibility and then to combine the results. But when they looked at the results and both were independently significant, they were separately published. And so those two studies set the standard for how we managed metastatic kidney cancer for many years until 2018, when 2018, when the Carmina trial was published. And in this study, they used sunitinib, and as you know, there was no difference in survival between the cytoreduction group and the no surgery group. So here are the two survival curves from SWOG 8949 and the Carmina study. One was a positive study with a difference in overall survival, and the other one was a negative study. I'm not going to do it today, but you can look at the two studies in detail and ask, why did they reach different conclusions? And I've listed, 4 possible explanations. Maybe the Carmina study had higher risk patients. Maybe they had greater metastatic burden. Maybe they received a more effective therapy in the way of sunitinib rather than interferon. Or maybe they received a TKI, and that led to the difference. If you want to look at a detailed analysis of each of these explanations, we did write a paper back in 2019 exploring those possibilities. But we had to conclude that there's no way to come to a definite conclusion. And so I put a bunch of maybes here. And I would say we do have equipoise when it comes to performing cytoreductive nephrectomy. In my opinion, we need more data, and the biggest reason we need more data is that therapies have changed. So I like these slides just to illustrate something that I find, that we all know about, but it's dramatic when you look at it this way. So for many years, there was a steady increase in new clinical trials looking at various cancer immunotherapies. And when I finished my training, I started my career with the Career Development Grant looking at cancer immunotherapy. And it felt very lonely because everyone was looking at small molecules, and that was sort of the hot approach to treating cancer. But things did change. First, there was Provenge in 2010, and then ipilimumab was FDA approved the very next year. And then Pembro and nivolumab were approved in 2014, and then we see this, and that curve has just continued to increase. So initially, there were 30 years of negative trials. Checkpoint inhibitors changed everything. And here you can see some responses in a recent trial. This is the impressive thing is 100% response rate. So you're seeing CRs in are up in 10%, over 10% of patients. So the systemic therapies for metastatic kidney cancer have changed very much since since SWOG and EORTC published their results in 2001, and since Carmina was published. And so the question of whether we should be doing cytoreductive nephrectomy remains very much unanswered, unfortunately. What about the timing for surgery? If you want to do surgery, when should you be doing it? To look at this question, we can look at this study, the CERTIME study, which was conducted in the UK. And this study compared patients with newly diagnosed metastatic kidney cancer who were randomized to nephrectomy followed by sunitinib to patients who had sunitinib first and then had nephrectomy. The primary endpoint was progression-free survival, and the study was initially designed to accrue 458 patients over 3 years, but the accrual was poor, and they only had 64 patients after 3 years of enrollment. And so the study was redesigned to look at progression-free survival at 28 weeks, and they were looking for a 20% increase in progression-free survival with the delayed nephrectomy. And the number of patients they needed was 98. So the study ended after randomizing 99 patients. And here's the progression-free survival curve. It looks like a single curve because the two arms had equal survival. But what's interesting is if you look at overall survival, there was a difference in the two arms. This was not the primary endpoint, so it's a hypothesis-generating observation. But the patients who had a deferred nephrectomy had longer overall survival. So here are some of the observations that I just talked to you about. In Carmina, immediate nephrectomy and no nephrectomy had the same survival. And so in that setting, of course, no nephrectomy is better because you're going to avoid the morbidity of treatment. So that's the better arm. In CERTIME, if you look at the overall survival curves, you might conclude deferred nephrectomy is better, and that difference was significant. So then when we were designing PROBE, we naturally then designed a study to compare these two arms that were circled. So deferred nephrectomy versus no nephrectomy in the setting of contemporary immunotherapy. So here's the PROBE trial. It's SWOG 1931, and Olga Fashion-Payan, who's a medical oncologist at the University of Michigan, is a co-PI with me, and we are leading this trial. Here's the study schema. We take patients with metastatic renal cell carcinoma, newly diagnosed. All histologies are allowed except collecting duct carcinoma, and patients receive induction chemotherapy, induction systemic therapy with a checkpoint inhibitor and a TKI or a second checkpoint inhibitor. And if you have a complete response in all your metastatic sites, then I think everyone would agree that patients should have a nephrectomy. So that patient is no longer on the trial. If your disease is progressing on 3 months of induction therapy, that patient's unlikely to benefit from surgery, so that patient is also off trial. However, if you have a partial response or stable disease and your considered a surgical candidate based on a urologic evaluation, you're then randomized to systemic therapy or nephrectomy. The primary endpoint is overall survival. We have a couple of stratification factors listed there. The key eligibilities are histologically proven through a biopsy of clear cell or non-clear cell RCC. You have to have metastatic disease, so just node-only metastasis doesn't qualify you. And then brain metastasis is excluded, and then you cannot have any contraindications to surgery. So what are some of the rationales for delaying cytoreduction and starting with immunotherapy? Well, immune-based combinations, have proven effective in the frontline settings, so that's something we need to recognize. Keeping the primary tumor in place may increase the antigen load when giving immunotherapy, and then delaying the nephrectomy may identify patients for whom nephrectomy is unlikely to provide benefit. For example, the patients who are rapidly progressing on systemic treatment. I want to show you some data that we generated from my lab. We did this a couple of years ago. We never actually got around to publishing it because we got distracted with other projects, but it's relevant to this discussion. When you do have a primary tumor in place, you do generate an immune response to the private patient-specific mutations in that tumor. To show that, we sequenced the DNA from the tumor and the normal kidney, and then we cataloged all the tumor-specific mutations, the private mutations in that tumor. And then we looked at the RNA to see if those mutated regions were expressed as RNA, and presumably they would then be transcribed and become protein. And then we created peptides that were specific for each mutation. And we probed the patient's white cells looking for a patient a tumor-specific interferon gamma response from the CD8 cells. And we can see that if you probe with the mutated peptide, you get an interferon gamma response, but the corresponding wild-type peptide does not generate a interferon gamma response. So this shows you that you get a tumor-specific immune response, and perhaps leaving the primary in place when you give checkpoint inhibitors can help make this immune response more robust and maybe allow the immune response to go beyond just those private mutations to other tumor antigens. Now, going back to the probe study, here are the statistics. The study is designed to look for a 12-month difference in median overall survival. So this is a big difference. The hazard ratio we're looking for is 0.68. I want to point out that in SIR time, there was a 17.4-month difference in overall survival between deferred nephrectomy and immediate nephrectomy. So that gave us the confidence to look for a 12-month difference. The study requires 302 eligible patients, and so if we account for 20% not being randomized or 10% ultimately turning out not to be eligible, we need 364 patients. We designed the study to accrue over 6 years at 4.2 patients per month. These are the drugs that are currently allowed. These are all 5 FDA-approved checkpoint inhibitor-based combinations. And here are the accruals up till now. So the yellow line, it represents 4.2 patients per month. And as you can see, we're not quite there yet. And so, we have not had a month where we've had no accrual, but we clearly haven't been hitting our target except for 1 month in July of 2022. And so, I hope you guys will all agree that this is an important study. Excuse me, yeah, that addresses a very important question, and we would like your support. There is a very similar study in Scandinavia called the Nordic Sun trial. It has almost the same design as PROBE, but patients can be randomized after 3 or 6 months after starting an immunotherapy-based combination, and their target accrual is 400 patients, and that study activated in July of 2020. So here is the summary about the cytoreduction. So I think it's fair to say that immediate cytoreduction is no longer the standard of care. It doesn't mean you can't do it. It's just not. It's not for everyone. We shouldn't be doing it automatically. Deferred nephrectomy may identify best candidates for surgery. I think that's also a fair statement. After starting systemic therapy, if you have a CR and all the meds, I think we all agree that cytoreduction would allow you to then convert that patient to a true CR. Again, if you have progressive disease or worsening performance status, you shouldn't do any surgery. The patients who have SD or PR, that's where questions arise. You can continue systemic therapy, you could do cytoreduction, but what I would encourage everyone to do is put that patient on the PROBE trial. So with that, I will pause for any questions or comments. Okay, not hearing any. Let me go on.
Hyung, I have a question for you. It's Ted. What is your sense? It seems like a very rational and appropriate, question to ask. Where do you think the limitation, or where do you think the hesitancy is coming from in terms of just your more limited accrual? Is it just dissemination of the trial itself, that it exists, or do you think that? I'm just curious. Yeah,
it requires medical oncology and surgical oncology to work together, and the timing of all the treatments can be a little bit challenging, but I don't think it's all that difficult. I do wonder, I do think that amongst surgeons, I think there's a lot of many of them continue to believe that cytoreduction should be performed whenever possible in all patients. So I think that is a little bit of a challenge. But I think I'm hopeful that as the word gets out and groups like you invite me to give these talks, that there will be more enthusiasm for this trial. What do you guys think? Do you think this is a study that could work well at a place like Northwestern?
Yeah, Hyung, I'm on a train right now, so I apologize if it's kind of noisy. Maybe we can also touch base later, but we have a close working relationship, of course, with the medical oncologist. We share clinic space, frequently communicate, and I think the trial sounds very promising, and I think we could contribute quite a decent volume of patients, and we can touch base with about that later.
Great. We'd love to continue this discussion with you.
Yeah, hi, I'm Mike Kahn. I'm one of the oncologists out here. One of my colleagues actually presented a case at our tumor board earlier today that would probably have been a perfect candidate for a trial like this. So if everybody recalls Chris's case from earlier this afternoon. So yeah, so I think I think it's a trial that we would really, I would like to have this trial available. It'd be very nice.
Yeah, and I'll admit at our center, we haven't done as well as I would have liked, and we did have some competing trials. So there are some industry studies. as well as cooperative group trials in the frontline setting that this could at least partially compete with. But then there are patients you're going to encounter where this could be the perfect trial. All right. Well, thank you for your questions and comments. So as promised, so here's how you do the cactus to cloud hike. You need to make sure you're in shape. So do a 5,000 feet climb about 2 weeks prior to the cactus to cloud hike. You need to carry about 1.5 gallons of water. You can't do this in the summer. It's just too hot. That's when people really get in trouble. You got to do it ideally in the spring, and carry crampons and ice axes in the winter. The trail is sometimes hard to find, so you should have GPS. And then the most important thing is you got to start when it's dark, so that as you go, as the heat, as the bottom gets hot and the heat rises up the mountain, you're ahead of the heat. And then if you're halfway up the mountain and you feel like turning back, do not turn back, because when you turn back into the 120-degree desert heat, that's where people get into trouble. So once you commit to doing the climb, you got to make it to the top. All right. So hopefully you guys can at some point come to Southern Cal and get to do that hike. All right, let's move on and talk a little bit about adjuvant therapy. Here, this is I want to just share some information here, not necessarily plugging any trials, but let me show you the CT scan. And this is a typical patient who has localized disease, but the disease is based on the size and pathology, may turn out to be a high-risk cancer with significant risk of recurrence. This is just a historic slide. I've listed just some of the randomized trials in the pre-TKI era. All these studies were negative, and so for many decades, we've been looking for effective adjuvant therapies. The NCCN guidelines now list 2 adjuvant therapies that we can consider that are FDA approved. So if you have stage 2 or 3, you can consider pembrolizumab. For stage 2 disease, so tumors over 7 centimeters in size, you can consider pembrolizumab if they are high grade or they have sarcomatoid features. Now, for stage 3, sunitinib is also listed, but it has a category 3 recommendation. And to remind you, this means that there is major disagreement between amongst the committee members as to whether the intervention is appropriate. And when sunitinib was being FDA approved, there was an advisory committee, and the vote to recommend sunitinib as adjuvant therapy was 6-6. So this is a controversial drug, and I want to just explain why the controversy exists. But before I do, I want to give you the wish list. As a field, when we think about adjuvant therapy, we want something that has proven OS benefit, and we want to see multiple trials showing a consistent benefit, either with the same drug or with drugs in the same class. And I think these are the two things on our wish list for adjuvant therapy. When you think about adjuvant therapy, you can think about the FDA-approved drugs. There are VEGF receptor TKIs, checkpoint inhibitors, and mTOR inhibitors. And these are the drugs that you would test in the adjuvant setting. So the first one is the VEGF receptor TKI that brings us to sunitinib and the S-TRACK trial. Here, patients were randomized to sunitinib versus placebo. The primary endpoint was disease-free survival, and the study met that endpoint. It had a hazard ratio of 0.76 and a significant p-value. The study was considered a positive trial. It was published in the New England Journal of Medicine, but the overall survival curves overlapped. And this was not the curve published in the original article. This was published 2 years later in European Urology after there was longer follow-up for OS, and this was their final OS analysis. And again, you can see that there is no separation in the curves. Now, there was another trial, the Assured trial, which was a 3-arm study, and this was a very large study sponsored by ECOG. And there were 3 arms. Patients either took sunitinib, sorafenib, or placebo in the adjuvant setting, and all 3 curves completely overlapped. So this was a very negative study. So the NCCN gives us a grade 3 recommendation because there's no OS survival benefit, and almost half the patients had grade 3 AEs. And really importantly, there are a lot of phase 3 trials of other TKIs that are now reported and are negative, and I've listed them here: Assure, Source, Protect, Atlas. So sorafenib, sunitinib, pazopanib, axitinib have all been studied. Adjuvant therapies were given for 1 year in most trials, but sometimes 3 years. And again, there was no benefit to progression-free survival. And so, sunitinib is approved, but its use is controversial. What about checkpoint inhibitors? So this brings us to the Keynote 564 trial, which is a very large study of nearly 1,000 patients with a median follow-up of 2 years. And the primary endpoint was disease-free survival. And it also met its primary endpoint with the p-value of 0.002 and a hazard ratio of 0.68. And the benefit appeared to apply to all the subgroups that they looked at, which is reassuring. About a third of the patients had grade 3 AEs. 20% discontinued due to those AEs. There were no deaths due to pembrolizumab. Here are the key eligibilities for the study. They enrolled, as I mentioned, T2 grade 4 or sarcomatoid. Patients with M1 disease could enroll as long as they were surgically NED within a year of nephrectomy. So solitary MET, you resect the MET, you could go on the trial. N+ disease was included, and the study only included clear cell histology. And here's the OS survival curve that was published in the original report in the New England Journal. And you can see that the hazard ratio is 0.54, and the confidence interval does not cross 1. The p-value would be less than 0.05, but it wasn't reported because the data was considered immature. The study was designed to report OS after 26% of all total expected deaths had occurred, and at the time of this report, that had not occurred. Just a few weeks ago, an updated study was reported with longer follow-up, and that was in Lancet Oncology. I'm not going to show you the curve, but the hazard ratio was 0.52, so it got a little bit better, but the OS data was still not mature. So we don't have the final answer on OS, but it's certainly looking promising. What about other trials using checkpoint inhibitors? Well, InMotion 010 looked at atezolizumab, and unfortunately, it was a negative study. Prosper was a cooperative group trial led by ECOG, and the design here is a little bit different. Patients got a dose of nivolumab before nephrectomy, and then continued nivolumab. The control arm just had nephrectomy. And this study was also reported at ESMO 2022. Unfortunately, it was a negative study as well. I want to just take a quick detour to mention um, and that there may be a role for pre-surgical systemic therapies, and maybe you need to give it for more than a single dose. Maybe you need to give more than a single dose. This is an old a plot from a study that we did many years ago, but just wanted to make the point that if you give neoadjuvant therapy, the primary tumor can shrink, and it can facilitate surgical resection. And then here's a picture of one where the tumor shrinks, and it was much easier to do a partial nephrectomy. So this was certainly not an endpoint looked at in the cooperative group trials, but perhaps it's something that we can consider in future trials. So going back to the Keynote 564 results, NCCN does recommend pembrolizumab in the adjuvant setting. OS benefit has not been formally demonstrated yet. The grade 3 AIs occurred in about a third of the patients, but at this point, the enthusiasm for this trial is a little bit dampered by the results of IMMotion 010 and PROSPER. Now, we all know that in the metastatic setting, we use, let me talk about the mTOR inhibitor. So SWOG 0931, the Everest trial, looked at the role of everolimus in the adjuvant setting. And this study has not been published, but has been reported. The study enrolled intermediate high risk and very high risk patients. So this is an important point to keep in mind. And here is the curve for the recurrence-free survival, which was a primary endpoint. The one-sided p-value was 0.025. This was the cutoff for significance. It hit the cutoff, but it didn't cross it. So it barely missed that significance, which is heartbreaking. If you look at the subgroup analysis, and look at the very high risk patients, you see a significant p-value. This is all hypothesis generating since it wasn't part of the primary endpoint. But the intermediate risk group didn't seem to derive any benefit. So, summarizing the Everest trial, it narrowly missed the significance level. The recurrence-free survival seemed to benefit the high-risk patients, and then 21% where there was a 21% improvement in recurrence-free survival. Now, where do you go with with this data? I'm not sure. I know that at SWOG there have been discussions about whether you can repeat a study like this in just a high-risk group, or whether you can combine everolimus now with pembrolizumab and run a trial. I'm not sure, but this is an interesting result. All right, now let me talk about combination therapy, which is what you now use in the frontline setting. So you can use combination of checkpoint inhibitors. You can use a checkpoint inhibitor with the TKI. You can use a checkpoint inhibitor with not yet HIF2 alpha inhibitor, but perhaps in the near future. So looking at studies that have examined combination therapy in the adjuvant setting, you have Checkmate 914. Here you have 3 arms: ipi-nivo, placebo-nivo, and placebo. If we look at the results here, there are 2 parts. In part A, you're comparing ipi-nivo to placebo. This result has been presented, and the disease-free survival endpoint was negative. The nivo versus placebo is, it's hard to imagine that being positive, but those results are expected in 2024. LightSpark is the newest trial that activated. It's comparing pembro plus bevacizumab, a HIF2 alpha inhibitor, to pembro plus placebo. So it's the first study that doesn't have a pure placebo control group. Primary endpoint is disease-free survival, and the study won't result for many more years. So I showed you this slide at the beginning of the adjuvant therapy part of this talk. What we're looking for is proven OS benefit, multiple trials showing a consistent benefit for a class of drugs. And I don't think we're quite there yet. And until then, trials will continue to have placebo or observation controls. So the take-home message is that for clear cell RCC at high risk for recurrence after surgery, you can consider pembrolizumab or sunitinib. I think there's clearly more enthusiasm for pembro than sunitinib. We don't have a drug class with multiple positive trials. There's no therapy that has proven OS benefit. The evidence for adjuvant therapy for non-clear cell RCC is very weak or perhaps non-existent. And future clinical trials will identify optimal treatment after adjuvant therapy, because some of those patients will clearly recur too. So, I wish I could make it any easier than this. I showed this slide once to my to my residents. If you have kids, none of them ever seem put the toilet paper back, refill the toilet paper. So this makes it really easy. And then one of my residents showed me this and said, yeah, you can actually make it easier. So I thought that was cute. Well, that's it. So thank you for your attention. And if anyone has any questions or comments, I'd love to take them.
I just wanted to thank you again, Dr. Kim. I think that you heard that there's some interest from Kent and others here to for your trial, and so we'll certainly reach out to you and see if we can get it open within our system. Dr. Khan, who's one of our other medical oncologists, commented that there was interest in some of the regions across Northwestern, and we're trying to open these types of trials across system. And so, I love that you presented it here. I mean, the whole thing was great. As a side point, as I mentioned in the chat, that's a hike that's near my parents' winter in Palm Springs, and that's a hike that I have on my list. So thank you for the tips and tricks. And if Ted just said, if I take your advice and don't turn back, I should survive to continue to do a urologic oncology here at Northwestern.
Yeah, thanks a lot, Hyung. That was great. Yeah. I really appreciate it. We'll talk soon.
That was great, Hyung. Thank you very much.
Again, thank you for the invitation, and it's always great to connect with old friends.
Very nice work, Hyung. Renal cell has gone such a long day. I remember the days of sleepless nights of high dose interleukin.
Yeah, no, I don't think too many people miss those days, right?
No. For sure.
Hyung, and congratulations on your newly defined role. Sorry, Ted.
Yeah, I was going to say, Hyung, just if you're interested, we have this conference every other Thursday, and we have really spectacular internal and outside speakers, just like yourself. So if your residents are interested in an opportunity to listen and so forth, they're live, and then B, we post them on our YouTube channel so people can listen and watch. So I'll send you the links if the residents would be interested.
Absolutely. We'll put them, we'll pass it on to our program director, and she can make sure that everybody's aware and has the link, and we'll pass it on to our faculty as well. And we're thrilled to have one of your medical students joining us in July. So we were very happy about that.
She's going to be super. Okay, we'll see you at the AUA, Hyung.
Okay, thank you, everyone.